Great. Good afternoon. Welcome. Thank you for being patient with our technology. Thank you for joining us here today for University of Michigan Injury Center Distinguished Faculty Seminar. We are delighted to host these events and happy that you've joined us. We give a special welcome to those joining us remotely via our webcast. We are so pleased you've logged in for this event, and we hope you enjoy the experience. Please use the built-in texting capability if you are experiencing any problems or have any questions. Because many of you here may not be familiar with us, I'd like to share a little background about the University of Michigan Injury Center. We are a CDC-funded, university-supported injury control research center, one of 9 in the nation. Our focus is injury prevention, and that incorporates many topics and activities. Our special expertise is in violence intervention, transportation safety, prescription drug misuse, substance use, suicide, concussion, and many of our interventions and work tend to focus on teens and young adults. Besides educational activities like this one and our lunchtime seminar series, we offer internships, fellowships, symposia, conferences, dissemination and policy support, statistical assistance, funding for pilot studies, and a whole lot more. We invite you to pick up one of our brochures for more information about us and how to become a member. Other upcoming events and activities, our next Distinguished Faculty Seminar will take place on Wednesday, January 28th, and Charles Branna from the University of Pennsylvania will be joining us. And it'll be here in the School of Public Health from 4 to 5. Register for all of our events at our website, injurycenter.umich.edu. We are webcasting and recording today's session so that you can revisit and share it with others. We'll let you know when the webcast is available on the website. Now, today we are honored to have a very special speaker join us from the School of Social Work at the University of Washington. Dr. Richard Catalano is the Barley Dobb Professor for the Study and Prevention of Violence and the co-founder of his university's Social Development Research Group. For 35 years, he has led research and program development to promote positive youth development and prevent problem behavior. He has served on expert panels for the National Academy of Science, federal and state government, and foundations. He has published over 350 articles and book chapters. He is the co-developer of the Social Development Model, several parenting programs, the school-based program Raising Healthy Children, and the community prevention approach, Communities That Care. Today, he will talk to us about building prevention infrastructure to reduce delinquency, violence, and substance use, Communities That Care. Welcome.
Well, thank you for that kind introduction, and it's great to be here. The Distinguished Lecture Series means you've lost much of your hair. And I certainly am a model of that. So who am I and what's my experience? I'm a professor at the School of Social Work, and as Sarah has said, and also the co-founder of a group of researchers called the Social Development Research Group. And along with the founding director, David Hawkins, and I, who have been partners in crime and drugs and violence and many other things over the years, and our current director, Kevin Haggerty, and our colleagues for the last 35 years, we've been doing 3 different kinds of research. The first kind is we've been investigating what are the predictors of both positive development, things like academic success or gainful employment, as well as predictors of problems that get in the way of healthy development, things like substance abuse and violence, teen pregnancy, school dropout, depression and anxiety. But we don't stop at that point. Many academics are happy to know what the potential causes of these problems are or of positive development. We're committed to going a step further and actually trying to, if we understand what the predictors are, can we change them earlier in development and see if we put kids on a better trajectory. And so we've developed and then tested both youth development and prevention programs that Sarah just talked about, community-based, school-based, as well as family-based programs. In addition, we've developed and tested tools to build the capacity of states, communities, and schools to build prevention infrastructure, and that'll be the topic of my talk today. But I have four objectives today. I added one, I guess, in my sleep last night. I have four objectives today, and that is why should we care about prevention? Why is prevention important for all of us in this room as well as all of us across the country, no matter what type of work you're involved in? What's the research base for prevention science is the second thing that I'll talk about. And then how does communities that care build that infrastructure, and what happens when this intervention does that to community-wide rates of violence, delinquency, and substance use. So, first objective. Why should we care about prevention? Due to the successive concerted worldwide efforts to address infectious disease and investments in child health, more children are surviving into adolescence, and there's been a shift in the leading causes of mortality from infectious disease to non-communicable diseases and conditions. And it's also noted that behavioral health problems are implicated in this shift. Let me show you a little data. These data are from the CDC, so our sponsors, we thank you, who may be on the webcast today, we heard. It's the leading causes of mortality for 15 to 24-year-olds. And these are the top 10 plus the other residual causes down at the bottom. But I want you to notice that 72% of all deaths are caused by these behavioral health problems. Motor vehicle crashes and other accidents, mental health problems leading to intentional self-harm, violence or homicide, and risky sexual activity leading to HIV and pregnancy as well. Now, this is for the whole country, and we know that some disadvantaged populations have even higher rates of these behavioral health problems causing mortality. For instance, this is data again from the CDC looking at American Indian, Alaskan Native populations, and here about 82% of the causes of mortality are due to these behavioral health problems. So even a greater number, and just a few points, suicide here is actually twice the rate for Native Americans as it was in the earlier chart, and drug and alcohol-related overdose, although in the earlier chart they might have contributed to accidents or violence or traffic fatalities. But in this case, they actually show up as the overdose itself as its own cause of mortality. So that's a notice there. Many of us work with public systems, juvenile justice and child welfare. And, should we really be concerned about prevention, or should we just be working with our kids that show up in CPS and foster care or are incarcerated? Or should we care about community-based prevention? We did a study in a kind of medium-sized eastern city, and there's about 5,000 kids involved in this study, and we've divided it up into a couple of different, we've cut the pie in a little different shapes. We looked at those that were those that were exposed to 10 or more risk factors and those that were exposed to 9 or less. And then we also cut it up based on whether they were in juvenile justice or foster care or never in juvenile justice or foster care. So you see all the populations here, and you can see that the system-involved kids, most of them are high risk. About 71%, as we would expect, are at high risk of having 10 or more behavioral health risk factors. While in the community, only 35% of the kids have exposed to 10 or more of these behavioral health risk factors. However, when you look at a community level, and we're in school public health, so I think we're concerned about the community as a whole, what you see is that the majority of high-risk youth are not in juvenile justice and foster care. In fact, 87% of them are in the community, living lives that are impacted by these behavioral health risk factors. So I think that even those of us who are working on the treatment or in the system end of working with kids have to recognize that we need to reduce the size of the community behavioral health risk reservoir, that behind the dam, not just the 13% that are coming out, or we may have a disaster. The public systems may actually be overwhelmed. Okay, hopefully I've done my first objective. I told you why prevention is important. I'm going to move on after a sum up. It's really critical. Prevention is critical for health and well-being. Behavioral health problems don't just cause problems in adolescence, of adolescent mortality, but they lead kids on a life course that also can cause problems in adulthood. So, and preventing these behavioral health problems, which we now know is possible during adolescence, can reduce mortality and morbidity over the life course. So, for instance, we know that of the people who are smokers in adults, about 80% of those who are smoking as adults started in adolescence. So if we could stop that earlier on, we would be likely to, have less cancers, less cardiovascular disease, etc. Okay, so if you're interested in prevention, where do you start, and why I think that many of us are interested in prevention, and there's many ways that you can intervene in a child's or adolescent's life, all the way from promotion through maintenance. And I think that my passion for prevention exists because I didn't start in prevention and promotion. In fact, I started in treatment and aftercare. It's where I cut my teeth early on in program development and research activities. And what I noticed, or David Hawkins and I noticed together, and our colleagues noticed, is that most of the children and adults that I'd worked with had already experienced the reinforcing effects of alcohol and other drugs. Most had experienced school failure and had little commitment to school or legal work. And many had experienced serious emotional trauma and were involved in violence towards others in their family, in their school, or their partners. If they were adolescents, they were in serious conflict with their families, and if they were adults, not only were they in conflict with their families, but they were leading a whole new generation down the same path. Improving the effectiveness of treatment and aftercare programs. Oops, I'm waving at the air here. How about this? Does this work? No. Yeah. No. It's very dull. Okay, never mind. How about this? No. Okay, no batteries today. It's important work that has to be done. We can't ignore that part of the work, treatment and aftercare. But by the time kids get to this stage, a lot of damage has been done to them, to their mates, to their families, as well as cost to society, and leading them on a trajectory that may not be that useful for them in their later life. So I kept thinking, wasn't there something that I could do beyond running an ambulance service at the bottom of a cliff underneath a sharp curve, where we could indeed patch these kids up and we could make a difference? And there are many evidence-based programs in treatment and aftercare that do make a difference. But wasn't there something we could do instead of waiting till they fell off the cliff? Couldn't we put up guardrails around that curve, to make sure the cars didn't careen over the cliff? Couldn't we also maybe put up signs that were further back from the curve that said, dangerous curve ahead, please slow down? Or maybe even take a step further back and say, maybe we should do good driver education for kids, as well as, I know Ray and Jeannie are like, I said, well, that's not that effective. And give kids more time in the car, to learn how to drive before they got their permits. Or maybe even step further back and say, since there's no microphone, I hope this is okay. stepping back away. Oh, look, sorry. Not something you do in the school of public health. Step further back and set up graduated driving policies where kids, need some supervised driving before they get their license, and they're not allowed to drive at night or with peers. And best, maybe couldn't we do all of these things instead of just letting the kid go over there? Target hardening, put up those guardrails, signs, education and experience as well as legal change. Couldn't we do all of that so that we could actually think as a society about preventing these problems? So I became an advocate for prevention and trying to find an effective approach to prevention. I think many of us are advocates for prevention. Sometimes it's a little harder than we think to develop effective prevention programs. There's a lot of people who are working very hard to try to prevent problems, and we know from the research literature that it's more than just good intentions and working hard to achieve positive results. A variety of promotion and prevention strategies, even when well implemented by well-meaning people, have had no effect, no impact on folks. So how do we as a field develop an effective approach to prevention? The idea has been around for a long time. Anybody know who said an ounce of prevention is worth a pound of cure? The first person who wrote it down? Yeah, that's it. Who said that? Raise your hand. You get extra points. All right. Ben Franklin, exactly. Was the first person to run it quite a while ago. But if we're going to go from an old adage to something that could turn into a science, we need a couple of things. The first is we need a framework for prevention. The prevention science framework says define the problem. This is also a public health approach to prevention. Define the problem. What is the problem that we're working on today? Is it dating violence? Is it traffic fatalities? Is it interpersonal violence? What is the problem that we're working on? Identify those things that predict that in the population. What predicts increased violence? That would be a risk factor if it's related in a positive way. And it would be a protective factor if exposed to that factor, people tended not to get involved in that particular problem. Then design interventions to reduce risk and enhance protection, implement your program well, and evaluate it. It's a great model. It's been around since they've cleaned out swamps, to make sure that malaria wasn't spread. It's a great idea. But in our field, we didn't really have the knowledge base to make this work. But today, we're in a much different situation. In fact, in 2009, the Institute of Medicine came out with this book that really was a summary of the progress of prevention science over the past 40 years. I recommend it to you if you haven't. How many people know this book? Okay, faculty all raising their hands. Okay, you have to transfer this knowledge to students, and that would be very useful. Really summarized these areas of work or prevention science research advances. Identifying risk and protective factors for a variety of different disorders, and as well as describe the distribution of these risk and protective factors across populations and communities. Also, as this information became more available, funding agencies started funding programs that would reduce risk and enhance protection. And we now know more about efficacy trials of these programs to design and test preventive interventions to interrupt the potential causal processes that lead to youth problems. And now we're in an era, I think, of dissemination and effectiveness trials in research, where we're really trying to understand how to build effective infrastructure in communities so that prevention science can achieve community-wide impact, not just in our randomized trials that we conduct. So David Hawkins, I, and our colleagues and many others around the world have contributed to this work on risk factors for adolescent behavioral health problems. I know This is a very difficult chart to read. We've published about 12 articles on it. It's easily Googled. You can get all the backup information you need. If you look at Hawkins or Catalano, we have several of these articles published. But I just want to make a few points here. First of all, just to understand the chart, the behavioral risk factors are along the side. The behavior problems behavioral health problems that they predict are along the top. So the top has substance abuse, delinquency, teen pregnancy, dropout, violence, depression, and anxiety. And if you see a check, or in this case, it looks like I have a couple of arrows here. There's no difference between the checks and the arrows. This particular version of PowerPoint changed some of my checks, apparently, into arrows. But if you see a check at the intersection of a row and a column, like availability of drugs is the first one up. Availability of drugs in a community, if there's high rates of availability, can actually increase the levels of substance abuse and youth violence in those communities. You get the idea. I think there's a lot of things you know about here you might not know about. Transitions and mobility. A lot of in and out migration increases the rates of different problems: substance abuse, delinquency, school dropout, and depression and anxiety. And some things you all know about, like economic deprivation, is a fairly pervasive risk factor at the community level. But there's also family risk factors, including a family history of the specific problem, family management problems, not knowing where your child is and who they're with, not not setting good rules for your kids, not having good guidelines for their behavior, and then maybe either inconsistent or harsh discipline, both leading to rates of increase in all these problem behaviors. And in fact, if you see the family factors, they're fairly pervasive risk factors across all the problems, as well as school risk factors: academic failure and lack of commitment to school, and then a variety of individual and peer factors, including early aggressiveness, friends who are engaged in the problem behavior, and early initiation. Just a few things to note on this chart. Each environment can predict having one of these problems. There's a lot of risk factors that are actually risk factors for multiple problems. That means we have an economy of scale in prevention. If we're addressing family management problems, for instance, we're likely to have an impact not just on substance abuse and violence, but also delinquency, teen pregnancy, school. You get the idea. Okay, so it's an interesting phenomenon that we should indeed be looking when we're intervening in these ways for multiple outcomes across these problems. Some of the most interesting research has been done in the last 40 years, has been done in identifying protective factors for multiple problems. And these are both individual characteristics as well as characteristics of the environment. And researchers did this by recognizing that not all kids living in high-risk environments develop problems. In fact, probably I like to use family history of alcoholism, particular fathers to sons, transmission of alcoholism. We know it's fathers of alcoholics. Alcoholic fathers transmit alcoholism to their sons at high rates, and it's a risk factor. It's an important risk factor. But it's if you look at the population level studies, in the population is between 9 and 12% are alcoholics. If you look at sons of fathers who are alcoholics, it's somewhere between 19 to 27%. So 2 to 4 times the risk. It increases the risk, but then people said, well, why didn't everybody get this problem? Well, they found protective factors in their lives that were either individual characteristics like a resilient temperament, the ability to bounce back, a variety of competencies and skills, and then in each social domain, positive opportunities for kids to get involved, reinforcement for pro-social involvement, strong attachments or bonding or commitment to a line of action, and healthy beliefs and clear standards. So both of these are important in trying, and when you're understanding predictors. And also, we know that different neighborhoods have different profiles of risk protection and outcomes. What this means is that we might have to take a place-based approach if we're thinking of working in neighborhoods. We were talking about Flint earlier today and the kinds of prevention projects that are going on there. This is Redlands, California, a different place. But what you see in this one area, now there's no mountains in Redlands. What we've done is made risk into topography here. I don't know if it comes across as well as it does on my screen, but you see at least neighborhood 2 and 3. Neighborhood 2 is the biggest mountain of risk, has the biggest, kids in that area are exposed to the most risk. It's a low income, high crime neighborhood. A lot of kids aren't doing well in school, and it certainly is the highest risk neighborhood in that area. And probably needs some of these kinds of things, neighborhood kinds of interventions, because there's a lot of community disorganization, crime interventions, things to deal with academic success. But neighborhood 3 is the second highest mountain of risk. Now, it's not as high, we can see that, but it has it's a more affluent neighborhood, and it has the kinds of risk factors that kids are exposed to there are things like favorable attitudes towards drug use. You have to trust me on this. I'm not showing you that data. I could, but I am not. Parental attitudes favorable to drug use and peers involved in drug use. So those are the things that are elevating that particular area to be high. You would do different things in these two communities if you're going to do preventive activities. There's different kinds of risks that are elevated that you might want to address. So what we know about risk and protective factors is individuals' level of risk and protection make a difference. Common risk and protective factors predict diverse problems and academic outcomes. And risk factors and protective factors show much consistency in effects across these diverse groups. And we've seen that effect across gender, across racial and economic groups as well, across states, even across countries. And different neighborhoods have different levels of risk and protection. So science-guided prevention interventions should target these malleable risk and protective factors. Not all of them are malleable, but we should use those as targets for our preventive interventions. My colleagues and I from around the globe did an issue or an article in the Lancet series on adolescent health, where we talked about the worldwide application of prevention science in adolescent health, and we identify in part of that work, in order to lead up to this article, we had to identify what were tested and effective approaches across a variety of problem behaviors. And so it's like, wow, we found a lot of things, over 100 programs across these different kinds of problems across the top and different kinds of programs. Now, for me, being an old guy, when I started my work in this area, I did a review for the Office of Juvenile Justice and Delinquency Prevention on effective delinquency prevention and substance abuse prevention programs. This was in the late 70s. And we looked at all the programs that could actually see if they make a difference or not, meaning they had to have a compared to what category, either experimental or quasi-experimental trial. We found 23 programs that were rigorous trials, if you will, and not a one of them worked. Now, for a guy like me, I see these checks and I just go, whoopee, look at that. Well, some of my younger colleagues see all the empty boxes here. So if those of you in the audience who are younger than me want to go for the empty boxes, there's a lot of work to be done. But there are prenatal and early childhood programs, parent training throughout the lifespan, after school recreation and mentoring, cognitive behavioral theory, therapy, things that you can do in schools, like how your classroom is organized and managed, or your instructional strategies, classroom curricula, and there's more. This was a little more sparsely populated, but things like motivational interviewing, youth development programs, certain policies like the minimum legal drinking age and access to contraceptives without parental permission, community mobilization, etc., have also been shown to be effective. So again, for me, it's like, yippee, we're done, right? Well, unfortunately, despite this progress, prevention approaches that don't work or haven't been evaluated are much more widely used than those shown to be efficacious. So the challenge that I see for you all in the room, a little bit for me, but I think for you all as well, is how can we build prevention infrastructure to increase the use of tested and effective policies and programs, prevention policy and programs, with fidelity and impact at scale, while recognizing that communities are different from one another. One size doesn't fit all, and we need to really decide locally at what policies and programs people use. So what am I talking about building prevention infrastructure? And so I think in order to use the research base, we have to build capacity of local coalitions. It's a really commonly done thing now to use local coalitions, and there's a lot of good ideas for why that might be the case. You saw those risk factors, they cut across, and protective factors, they cut across different sectors. You know, we're all siloed up in our treatment and prevention activities. Oh, I'm public health. Oh, I'm substance abuse. Oh, I'm, teen pregnancy. Oh, I'm, so we have to cut across those. Having coalitions that have members from all those areas, pretty critical in order to do that. But you have to build the capacity of those local coalitions to reduce common risk factors and multiple negative outcomes by teaching them how to assess, prioritize epidemiological levels of risk protection and problems, choosing programs that match their local priorities, and implementing those programs with fidelity to those targeted. That's a big ask. That's a big task in this society, particularly for local coalitions who may not have been trained. So we decided to embark on this Communities That Care to try to build prevention infrastructure. Now, we started this idea, what we developed in 1988, and we thought, oh, what a great idea. Let's see if we can do it, And so we spent 15 years falling on our face, standing up again and saying, we can take it, never give up, let's do it again. What do you guys say? How can we do this better? So we got a lot of community input prior to our randomized trial, which we began in 2003. And it's now been tested in a randomized trial at the community level, 12 pairs of matched communities across 7 states, from Maine to Washington. We like to call it the bi-coastal study. And it's also, its effects have been replicated in an independent test done in the state of Pennsylvania as well. So we like to think it's effective, not just efficacious. So what is Communities That Care? I'm going to go through this in lightning speed, and then I'm going to share the results, and we'll just end on that note. So I know when you start at 10 after, I don't know, can you go to 10 after? No, I think we'll make it. I know that there's lots of things that you all have planned to do tonight. So it starts with a get started phase where we assess and build community readiness. We try to look at all the different key groups in a community. Those might be ethnic groups, or it might be income groups, or it might be D's and R's, or whatever it is. But we really want to find out from everyone, what are the key issues for them? What's their experience with community coalitions and community mobilization? And to ask them what they think about prevention versus, oh, we've got to close the crack house down the street, or it's that dangerous intersection that we have to do something about. We want to do this because we don't want to be surprised later on. If this is a community where when we all get together in our coalition and say, let's put our money on the table and we'll figure out how to do it, and some guy says, hey, look out the window over there, and they look out and they are distracted, they come back to the table, and the guy and the money are gone. This is a community we have to kind of build trust first with before we can get into collaboration. So sometimes that community readiness building has to be done at the beginning. We can't just dive in. We then get organized by training key leaders, those who are police chiefs, mayors, judges, business leaders, faith leaders, those that have a stake in the community and might be able to provide community resources to understand the model and why and what they're getting involved in if indeed they choose to move forward. And then we train a community coalition or a community board to lead the effort, because the key leaders aren't going to lead it, but they have to bless it and understand that when you get to this implement and evaluate, or at the create a plan stage, that community coalition is going to ask them for money to help put these new evidence-based programs in place. So we then build capacity of the community coalition to do this. We help them develop a profile. We do this using a youth survey of 6th, 8th, 10th, and 12th graders. This survey has at least 15 years in development and testing. It's probably more like 20 years now. It's really has reliable and valid measures of risk and protective factors and delinquency, drug use, and depression that is good across state, gender, age, racial, and ethnic groups. It identifies risk and protective factors and provides a foundation for selecting tested effective actions. I'll show you an example of that, and it also can be used to monitor progress. You do it every 2 years, so you can see did it make a difference or not. The next step is after the survey is done, people make a plan to, they prioritize the risk factors, select programs. I'll show you an example. So here's a risk profile. We've been able to actually standardize the way it's presented so that you can compare one risk factor to the other as the percentage of kids that are put at risk given their particular score on this risk factor. I know you can't read all the bottom things. That's all the risk factors in the community, family, school, and parent individual area I showed you before. And you can see at one glance here that, you know, there's some family elevated factors. There's some individual elevated factors, but I'm just going to focus on the family for now. And so there's two things here. It says poor family management. I can read this. I don't know if you can. And parental attitudes towards drug use are the two elevated risk factors. Now, we allow communities to choose the ones they want to choose. They're not likely to look at the perceived availability of handguns, which is very low compared to the national averages here. But they might choose these ones that are higher in this case. They might not choose the highest ones. That's up to them. So it's their choices involved. We then lead them to a matrix of if family management and favorable parental attitudes are your problem, there are different evidence-based programs or types of evidence-based programs you can choose from. Can you read that? Somewhat? No, you're looking at me, not up there. It says prenatal infancy, early childhood education, parent training, family therapy. That's in the first box. Prenatal infancy programs, parent training, community school policies. I just say, suppose you chose parent training activities. There's a variety of efficacious parent training activities you can now explore, see which one fits with your community, which one might be better for you as a community. They all address those two risk factors. But different communities have different priorities. Here's a different one. None of those family factors are really all that elevated. Here, academic failure, community disorganization, and interaction with antisocial peers are all elevated. I'm just going to pick academic failure for now. There's different set of interventions that you might do here for this community versus the other one. And then there's a variety of classroom organization, management, and instructional strategies. So you get the idea. Look what the elevated risk factors are. Community choice, you pick it, figure out what it is. Tools to help them get to the right programs that address those risk factors. And then try it out. Figure out which ones might be able to work given what you know about your community. They form task forces on each one, identify and train implementers, track fidelity and reach, and I'm going to show you a couple of examples of that. And then the circle starts again. 2 years later, you know, there might be new key leaders, there might be new community coalition members, so you got to get started and ready, and you look at your risk assessment again 2 years later. This whole process of the kind of training and getting this moving takes about 6 to 9 months. It can take a year or more if a community is really at war with each other and they're not working well together, so you have to get through community readiness issues. But if you can get through, generally most communities take 6 to 9 months. At about a year, they're implementing these evidence-based programs, and we expect in 2 to 5 years changes in risk and protection, and 3 to 10 years increases in positive and negative, hopefully increases in positive and reduction in negative behavior. So we tested this out. This is my last objective. I'm almost there. I have 10 minutes. We tested community set care in a randomized trial in these blue states, I think. They're not Democratic necessarily, but they're in light blue. And they were matched pairs within states. Most states had 2 matched pairs. So that's 4 communities. 1 state had only 2 matched pairs. Or you would see 28 here. I guess maybe 2 states only had 2 matched pairs. 1 matched pair. And they were randomly assigned, these communities were randomly assigned to control or CTC condition. They were, again, were incorporated towns ranging from about 2,000 size to about 50,000 size. We did a 5-year implementation phase where we did the CTC process and implemented the tested programs, and actually since in 5 years they could check their risk profile a couple of times. They adjusted their plans, and then we did a 3-year follow-up. We evaluated this by getting a cohort of kids that were in public schools. We got about 4,400 across the 24 communities. They were surveyed annually in 8th grade. We have very high response rates. And a high initial response rate in the mid-80s, and then a 90% follow-up rate. So we got them wherever they went afterwards. It takes a village of funders to raise this kind of community trial. The National Institute on Drug Abuse provided about 60% of the funding. 40% was contributed by these other agencies that are here, including other national institutes, as well as the Center for Substance Abuse Prevention. And we also had to have state collaborators. Each of the single state offices that were responsible for drug and over time mental health prevention were on board in each of the states, and were our true collaborators in this study. Complicated idea. This is just our theory of change. We say at the left side here that the CTC implementation of training and technical assistance, that's our intervention. We thought it would lead to these kinds of things like the adoption of science-based approaches, more collaboration, more community support for prevention, stronger community norms, as well as using the social development strategy. We found many of these intervening variables work the top 3, and community norms, there's actually some evidence now as well. We then thought if those things were in place, we would have, they would choose appropriate prevention program selection and implement them well with fidelity. We'd see a decrease in risk and enhanced protection, and some changes in youth behavior at the community level. Again, tracked through this community-wide survey of 5th grade students. So you can see one thing was different communities do pick different risk factors. These are the 12 communities over the top, and although in the yellow you see that some in between 5 and 9 of those 12 communities pick some, the same similar risk factors like low commitment to school and academic failure and antisocial friends, there was certainly a diversity of communities picking different risk factors to target. Here, one picking laws and norms, three picking family conflict. So you can see the idea. They actually use the system, look at their elevated risk and protective factors, chose the ones they thought were most elevated. This is like you go to the doctor and you have flu versus you have a bacterial infection, so those you might get different treatments depending on what your presenting problem was. We think the same for communities, diagnose and treat as the community set care model. They put in a number of different programs. In the first year, they put in about 2 programs per tested effective programs per community. They did school-based types of programs that were mostly classroom curricula. They did after-school programs that include mentoring and tutoring, and several family-focused programs. And you can see people chose different programs based on their fit with community as well as their fit with their risk and protective factors. 2 things to notice on this. They moved to 3 per community in the second year, and 2 things are interesting, I think. They were able, by having a community coalition process, in the first year, only half of the communities actually got into the schools. But by the second year, all 12 communities have gotten into the schools with some school-based program. And that's, there's a lot of resistance in schools today, particularly with No Child Left Behind and high-stakes testing. But if you have a community coalition behind you, and you had the superintendent that said, oh yeah, I agree to this, even though superintendents last about 2 or 3 years these days, at least in our community. That's actually a long tenure, 3 years in Seattle. Even that's the case, they can get them into schools, and we got more community coalitions moving in that direction as well. And then you see there's little stars on this chart, which means the community, although we paid for we paid let's see, that was for the community. So about $75,000 per year per community to implement these, to get the training and technical assistance that they needed to implement the programs. Not to pay for staff necessarily, but to pay for the training and technical assistance. They started kicking their own money in. All those stars show that there are a lot of different local efforts. So the challenge in trying to get people to fidelity now, because we know that implementing an evidence-based program poorly is actually no better often than implementing an ineffective program as well. So our challenge was, how do we measure fidelity across this kind of big range of programs? Those were a lot of different programs, and encourage local ownership for high fidelity and sustainability. We measured all these different ways of collecting fidelity information, adherence, delivery of sessions. Did they do it the specified number, length, and frequency? How well were they done, and did people like them? Were they engaged in retaining the material? And our trick was, it wasn't us that did this observation. We did 2 things. We had fidelity checklists for each of the programs. The program implementer did it, and a board member. You see that guy with the kind of, I don't know what he's got, a little pencil, and it looks like he's got it on his chin. He's one of the community board members. In this case, he was, I don't remember, so I won't make it up. I can't remember, sorry, senior moment, that happens. In any case, he's in there observing, and so they also provided corrective feedback. So it wasn't us telling you you're not doing it right. So they noticed, for instance, that life skills training, they weren't doing it every week. They were supposed to do 1 session a week for X number of weeks. So they said, you guys have to do that. At one of the guiding good choices, one of the implementation checks is do the parent trainers greet parents at the door and start to create, an atmosphere of, mutual trust and moving together, or did they talk to each other? So we had people actually making those kinds of changes, as well as did they implement each of the pieces of the lesson. We had these two people do it. They had high rates of agreement, and they actually did provide corrective feedback. So we had high adherence rates for most of the programs, not all of the programs. This one that's the lowest here was only implemented in the last year, so it didn't really have a chance to get higher. But all of them are over, most of them are over 70%, and a lot of them are over 80 or 90%. Here's what happened. My last objective. Oh, I'm almost there. Again, written lots of articles. You can see these on our website. I'm not going to give you the full details of these outcomes. However, each of them are here. Each of the outcome points, the 08, 09, 12, and 14, correspond to each of these different grades. We didn't see any change right away. It took 3 years after we started CTC, that's 2 years after putting the program in place, before we saw our first effects. We saw targeted risk be reduced, and we saw delinquency, which is the most frequent problem behavior among kids, delinquency initiation be decreased in the experimental communities compared to the comparison communities. At 8th grade, delinquency and risk were joined by protection and a series of substances being reduced: alcohol, cigarettes, binge drinking, and smokeless tobacco. Some of these findings translated to prevalence rates, not just initiation, so how much they were doing, not just whether they started or not. 3 years, 2 years later, 1 year after the funding for TA and program support ended, most of these findings were maintained. And at 12th grade, we still had initiation differences in delinquency, violence, alcohol, and cigarette initiation. On the basis of that last time point, this was now 3 years after intervention, so it's a long enough follow-up period to say these effects lasted for this cohort. We did a cost-benefit study following our friends at the Washington State Institute of Public Policy, using their model. You can see where benefit comes from. It came from mostly from the delinquency and violence reductions. The benefits, if you looked at the total benefits, it was about $4,400 or almost $4,500 per kid intervened in. You can see it's about 5. I'm pointing to the screen. The red figure here is the cost. The top figure is the benefit. And according to the Washington State Institute for Public Policy, they say, you guys are developers. We're cutting your effect size in half. Even if you cut the effect size in half, you can see 2,300. You see that there's still a return of benefit over cost in their model 4, and our model, in the full model, the full effect size about $8 for every dollar invested. So it's somewhere between those two figures, probably between $4 and $8 per subject. So I'm there. CTC supports and sustains prevention with fidelity. It builds capacity to assess risk, protection, and youth outcomes. And I can't tell you how many community members carry their little risk assessment reports around to meetings and other places. And I thought, oh no, this is, how are they going to become citizen scientist advocates? And they were. And they match their priorities to evidence-based programs. I think that builds the capacity for them to ensure fidelity. They chose what risk factors. They chose the program. We're funding the program. We want it done right. Not Rico and Dave wanted it done right, but they wanted it done right. And in the long run, we see these kinds of outcomes, and it really does create citizen advocates for prevention science. Thanks a lot. You guys have been a very good audience, and you own the website as well. I talked too long for questions, but I can entertain any questions. If you guys would love to, ask something that you might be interested in, you probably have to vacate the room at 10 after, no doubt. Okay, we can take questions. You want me to talk about my language? Yeah. Oh, real.
Hi, how are you?
Good.
I'm wondering, in terms of working with communities, I know how challenging
Yeah.
it sounds like you had great success working with communities, particularly the communities. I wonder if you could share with us just some of your views about.
I think for me, the key is understanding the readiness issues in any community. So before you go in, or when you first go in, that's the better way of thinking about it. You really need to assess, first of all, who are the different groups in the communities. Everyone has, different groups with different opinions. In fact, you might even have people that are saying, we're into violence prevention, or we're into substance abuse prevention, or we're just trying to clean up this neighborhood. There's lots of different perspectives. You have to listen to those perspectives, number one. I think that's really important, and you have to make sure that you included all the critical groups in that community. I don't mean just the leaders either, I mean the grassroots people. What are the issues in this area? And you have to, how do you tie prevention to their issues? That's the next thing, and I think that's really critical. And one of the great things about, I think, this evidence-based for prevention science is that I don't care what banner I have to go into, whether it's substance abuse, delinquency, school dropout, teen pregnancy, or even if groups have different ones. Hey, but look, guys, common risk factors and protective factors predict all these problems. We can work together, have different endpoint goals, and still move ahead. So I think that's that part of educating about prevention science and its impact, et cetera. So I think we have to know where people are, because you can't go, well, we're substance abuse prevention, and everyone is there is worried about violence, and you just can't do that. You have to, that's just, an example. But you can see, we all know the different kinds of issues that communities present and come up with, and so we have to find ways of uniting them in some way. And at least knowing about them so that you're not, oh, well, we have this great substance abuse coalition, but nobody really cares about that issue. You're all caring about something else. So you've got to be able to do both of those things. The other thing is, part of that I didn't go into a lot of the details, but part of the board's job or the coalition's job is, we call it the PR committee, but it's really a communications committee. They've got to talk to all the groups in their community about what's going on. So it's not just at the front end. You got to bring people along all the way. So in our implementation in Seattle, we're currently doing with support from our dean of our school. I just can't believe she's investing $500,000. My dean, not a grant, not part of her money, in this, because we're working through practicum agencies in Seattle, in the more disadvantaged part of town, and that's where all our agencies are, because we're a social justice school that is doing working primarily in the central and southeast area of Seattle. And it was a response to our practicum agencies saying, you guys need to bring this together to think about evidence-based practice. Everyone's talking about how do we do it, what program should we choose, what's going on. We said, here's our response, communities that care. But we included all our practicum agencies and then got them together and said, who else isn't at the table? Who isn't a practicum agency that's also involved? So we got to that next group as well. This was all in the kind of community surveillance, community readiness area. And of course, there's in a city like Seattle, there's a lot of things going on. And so there's other coalitions that you have to deal with and what their issues are as well. So I'm giving you maybe a long answer to that question, but I think it's the initial readiness, making sure that you're outreaching to everyone else. And early, where are these lessons from? They're from mistakes I've made. Because I've had a great coalition planning group together, and then they showed the stuff to the community because we said, you've got to show it to everybody. Everybody said, who are you? And what are you doing? You know, you're not, you know, we've been here for 10 years. You came up 6 months ago. Who do you think you are? You know? So when those things, that's why we say you've got to get the readiness and you've got to communicate to every person. And you know, everyone doesn't have to accept. You know, there's also things that exist side by side. And they might not, you know, all come together, but you're still letting them know, you're informing them of what you're doing, you're giving them a chance for input at each stage. Show the risk priorities, you show the community groups, show the programs we're choosing, you show the community groups. Because many of them will want to get involved in implementing some of the programs as well. And then show the data, show the dashboard that you get, you know, in 2 years, in 4 years, etc. So you've got to keep people involved and join to make these things work. Because it is hard work. But, you know, in reality, there's no real system. I mean, public health is the closest, I think, in communities that kind of has the broad view, but it often is, it's often a partner, but it doesn't do all the things that communities that will do. So there's no real resident system. There's a lot of piecemeal. There's violence prevention, there's substance abuse prevention money, there's public health money. Who's bringing the actors together to think through those issues? Long answer. Yes.
You have what kind of prevention programs that you utilize?
Yes, we do. It's see this communitiesthatcare.net. You'll find our one there. But what we've done is, because we can't constantly keep it up, we're not in that business. We're actually now using the blueprints for healthy development, and it's www.blueprintsprograms.com. All one word, blueprints with an S, programs with an S.com. And we've worked with the Annie Casey Foundation and the people at the University of Colorado. We have that website to make the website more interactive, and actually to have you can pick programs by risk factor as well as other things, but that's made it compatible with CPC. Whoever, left to right.
One of our webcasts asked me to share.
Oh, yes.
She said that the community picture model quarterly board meeting is November 8th. Interested in the model.
Cool. You just had one more example of how to make sure that people are doing the communication. Yes.
So, do any of the communities have any of these evidence-based programs, say, culturally, and if they're not, if the standard is not put out, how do you handle any kind of that in terms of we need without this?
I've never heard that before. That's a joke, right? Of course. Everyone comes into it with that answer, because we are all different. You can see that. How are we different? We have different levels of risk that affect us. We might have different ways of communicating to each other. We might have different ways of recruiting our population. That might not be the way, you know, Familias Unidas does it, but maybe Guiding Good Choices does it a different way. Or maybe, you know, so how do we think about that? So we say there's lots of choice here. There's choice in which risk factors are, you know, that affect your kids in your community. There are often sets of programs that you can choose among. Which one fits your community the best? So if you saw that list of parent training programs, there's 6 or 7, and that's not the whole list. There's more at different ages as well. So that's another piece of getting congruency between community and the program. And then we say you should implement these with fidelity, but it doesn't say how you communicate with people using their language rather than the stilted language that often comes in program manuals. You have to be a skilled practitioner of the program. How you recruit people may be different. We did a trial with Guiding Good Choices, for instance, where we were implementing in different ethnic communities around the Seattle area, which is, kind of ethnic city, which is because it has multiple groups. No one group dominates, and we have, lots of Southeast Asians, Cubanos, folks from recent immigrants from Africa, as well as the traditional, Latinos, many different populations. So he said, well, I wonder what they would do. Mostly what people do is add things like, oh, we're going to have a dinner beforehand. We're going to recruit through churches versus somebody else recruits through schools versus, and those were effective ways of bringing people in. And then communicating in their language. I think not just language, but in the way that people speak, which means you need a facilitator that understands the population. But we still want to do skill practice. We still want to set guidelines and choices around alcohol and drug use. That's what that program does. We still want to talk about family conflict, despite that sometimes cultures have issues with family conflict. On the other hand, we can show that family conflict affects kids' behavior. No matter what the cultural norm is, it still affects kids' behavior. And some cultures have higher levels of conflict, some have lower levels of conflict. Sometimes low level is no good because everyone stuffs it, and does other things. But we still want to get family conflict to be expressed appropriately in ways that fit with that culture. So we've actually had success at fidelity and saturation, but we bring a lot of choice.
How do you make, how do you control policies, maybe are discussed this, or a lot of people will prefer to put policemen, will prefer to encourage more type of control, type of so how do you put them together to work in terms of with people from community, from church, both of them will decide what to do in that community, and thinking about the other type of control policy the county or the state that would say, no, these are drug issues in the community, so we need to put the intervention should be different from that prevention, life skill training, for example. So how do you put that together, or how do they coordinate in a community?
That's a really good question, and I have to say that I found strange bedfellows over time. So I'm just going to take a little bird walk first. And so that Redlands map I showed you, the police chief in Redlands was the champion in Redlands, the police chief for prevention. He said, if we don't do prevention, we're just, we're cleaning up, we're doing our part of it, but in reality, it's going to be a constant process of taking kids off the street unless we do something up front. I've had corrections people also be the strongest advocates for prevention as well. Now, it doesn't mean that you don't know that's why we did that assessment, the community assessment process or readiness assessment to talk about if the drug house is the big issue, you might have to solve that problem before you can get into prevention. So you have to get through the readiness and say, is prevention an option here or is only treatment? And, you have to tell the story. The same way, we got to turn off the faucet. Otherwise, we're going to the buckets will be filled by the tap is here and we can just keep doing that, or we could turn the faucet off, so maybe we should do a little bit of both, and we might have to clean up some parts of the control issues first before we can actually feel safe about prevention. So that happens. We don't start that effort there. You got the right people around the table because you're building that advocacy group. Maybe they need to do that first before they move to the next stage. So we've done all these things. I think we've also had really strong partnerships with people who get it and say, yeah, look, we'll take care of that, the police officers or the judges. But if we don't do this, we're in trouble. In fact, Jim Bierman is now the head of the Police Foundation, which is a training and technical assistance for all police chiefs around the country. And he says, if you've got a police citizen bad vibe, CTC is the best thing you can do for him. And he's really been an advocate for moving it into particularly troubled police departments who are having community reaction to police violence, if you will, or the police misconduct. He said it's a perfect thing because we're going to get ahead of the curve. That's where we need to be. That's what the community wants. But it's good for those kinds of departments. 20 after 5. Any last burning questions? Thank you.
Thank you very much. And I know evaluation forms were handed around. Please fill out the evaluation. Thank you so much.